All right, Aaron, recording is on. I'll turn it over to you for the intro.
Yep. All right. Thanks, John. Hi, everyone. Welcome to a Thursday Geospatial Forum. Reminder, this is our next to last for the semester in 2 weeks' time. We're on the 18th of November during GIS week. We've got 2 guest speakers, and that will be the final forum for this semester. So today, excited to have and to host Marynia Kolak. Dr. Kolak is from the University of Chicago. She's going to present today on the next US COVID Atlas, Reanimating Data Analytics with Stories, Connection, and Geographic Thinking. She is someone whose work I've become familiar with through Twitter and through seeing some of her articles. And we had a nice chat earlier just talking about the variety of her work, from social determinants of health and air quality, placement of trees, opioids. And so she could have given probably 4 or 5 very different talks today. And so I'm excited to hear where her work is with the US COVID Atlas. If you read her bio, you will notice that she's got degrees in geology, geography, but also has an MFA in writing. And so I'm curious how some of that public communication will come through in how she frames her work. Dr. Kolak is the Associate Director of Health Informatics for the Center of Spatial Data Science, and she's the lab PI of the Healthy Regions and Policy Lab there at the University of Chicago. I really like their page. There's probably a link to it in the bio, but they have a mission of integrating innovative GIS, GI science and public health statistical approaches to explore, understand, and promote healthy regions and policies. Their group is dedicated to open science and open source methodology and applications. We're committed to research, translation, and policy and public use. Each project has both a research and applied component. All those words speak to my heart. And so I'm super excited to be able to host you today, Dr. Kolak. And with that, welcome to our group. And I will turn it over to you.
Thank you so much for that super generous intro. And likewise, yeah, just honored to be here and also learn from your team and all that. So here, let me do my best to switch over to the topic of this. I have a couple screens here. So does that work? You guys can see this now? All right. So again, I'm Marynia, and you've learned a little bit about the lab, Healthy Regions Policies, and then we're situated at the Center for Spatial Data Science at U Chicago. So first, let me kind of start off by giving some context to some of what I'll be talking about and why. I'm sure that this happens to many of you as well when you're trying to explain what you do to other people who are not familiar with geography or GI science. They'll be like, oh, so you make maps, right? Sure. So yeah, yes, we make maps, and maps and visualizations are often kind of the very last step of a really long, intensive process. And it turns out that maps and visualization have a really long role in public health specifically, and also kind of wider in our culture. So I highlight 2 here. If you're not familiar, feel free to look them up a little bit more. The one on the left is by Charles Menard. And this is showing you kind of the impact of war through showing, so at the very left, you have Napoleon's army heading out to, to simplify, to go win a war. So as they kind of traverse through the really tough terrain and a lot of different things happen along the way, they reach their destination in Moscow, and the return back is in that black line. You can see that the line of soldiers returning in the final kind of very, very thin black line is much smaller than those departing. So this ended up being a really significant infographic back in the 1800s that was trying to communicate the perils of war. Edward Tufte, a really important kind of godfather of information design, writes about this graphic in depth and has scrutinized it to pieces by actually looking through all the other forms that were developed before this one that you see here. So this was not the first draft. This was There were dozens of different graphics. Some were done according to the actual geography, made to scale, others not. This was a really complicated task. And the final one that was chosen, that Menard chose to communicate, is what you see here. On the right-hand side, there is a graphic from Florence Nightingale, also from the 1800s, who is a famous nurse, but also a data scientist. And you're looking at a rose diagram that is also trying to communicate the perils of war. So here we're looking at causes of mortality in an army and how that changes from month to month. So I just wanted to highlight that this tradition of, there is this idea of trying to speak to the truth of data, whether it's spatial data or other types of data, but oftentimes what we communicate at the very end is there's some kind of motivation that goes into that, right? It's not the quote unquote rawest form of the data. There's a lot of insight and goals and motivations that go into it. So another really classic example that I learned in geography, GIS, that I'm sure all of you have learned, I always put this in my, geography 101 tests, the famous John Snow example. So another quote unquote godfather of geography and epidemiology. So here we're looking at a map of London, a neighborhood in London, and cases of cholera death and the Broad Street pump. So different locations of pumps. And back then, John Snow was trying to convince his colleagues that it wasn't, cholera was not spread through breathing. It was not airborne, but it was actually borne through infected water, right? So when I was initially taught this, I was taught that he made this map. It all kind of clicked together and things transformed. But it turns out the story is much more complicated. Some colleagues, Thomas Coleman and Julia Kaczynski, are writing extensively about this. I highly recommend looking into some of their work. Long story short, this map that you see here follows years and years and years, I think if not decades of work by John Snow, of going through multiple experiments to try to figure out exactly what is going on, but then also more difficult, explain it to his colleagues. So deciding to put a pump on the map, for example, was a very conscious data strategy, and finding the right example to communicate this. Like there's a lot of additional context that went into making this map. So what I'm trying to say is essentially how we consume and communicate data really shapes the stories that we tell. It also shapes how we think about it, and that it's going to shape how others respond to it. So how do we consume data? What uncertainty exists within that data? Do we trust that data? What are the issues? What data do we decide to include or not? How do we communicate that data? What are the visualization strategies? What stories are we telling or not telling? And all of that, right? So, and as GI science folks, we also know that our minds are designed to find patterns, even if the patterns aren't really there. So I also like to bring in things like math and statistics to help confirm that the stories that we think we see are really there. And so this was really exemplified by the pandemic. And so today I'll be talking a lot about our work with the US COVID Atlas. So for those of you who haven't seen this, there's a link at the uscovidatlas.org. So feel free to start perusing as I give you an overview. And here I tend to get long-winded, so I have a bit of a script, so just bear with me. So kind of travel back in time all the way back to the beginning of 2020, right? The pre-quote unquote COVID life time, which probably seems like a long time ago. So our team had actually been following the pandemic closely since the original outbreak in Wuhan back in December of 2019. Our center actually had an exchange program with Wuhan, and some of our colleagues were at Wuhan in early December. They came here before it broke out, but long story short, our group was really closely watching what was happening. As an FYI, Wuhan University has some of the best C programmers in the world. So that's one of the reasons that there is this connection between our teams there. So by early March, our team had identified several challenges emerging that impacted a more comprehensive understanding of COVID. First, there was a lack of publicly available county level COVID surveillance. And as geographers, we know that this is a problem, right? So by focusing on statewide or even US-wide metrics, it's easy to miss rapidly surging cases at a more local level. Identifying outbreaks early is really critical to isolate effectively. A hotspot would have to be pretty mature and therefore very difficult to handle or contain if it's already flagged as a hotspot at the state level, right? So, and some states are very large, so you don't ever want to wait till it's flagged at that state level. At the same time, back in March, there was a focus on large cities, right? So New York, in the very beginning, Seattle, and maybe just where you live, right? So one's own areas, but there maybe was not as much attention to what was happening in surrounding areas or what is the big picture. This makes it really difficult to understanding what's happening in a comprehensive way as things tend to get hidden, right? Adjusting for population was also not as prevalent in those days. And that was really important to understand what was happening in rural areas that were being disproportionately hit by COVID. I'll give you some examples of that later. And then finally, back in March 2020, there was only one crowdsourced data set existing that was providing COVID rates at the county level, 1.3 acres. You may not even be familiar with it. Though a few more data sets became available later, like Johns Hopkins, New York Times, USA Facts, at the county level specifically. But those different data sets weren't always consistent with each other, and there was no authoritative source. Today, we think of the CDC as an authoritative source, but that wasn't available until December. So finally, we saw an urgent need to quickly integrate community factors to show the local community context of COVID to assist with rapidly developing policy responses. So there was born the US COVID Atlas. We kind of started around March 14th. It was launched by March 24th. The US COVID Atlas is a county level visualization tool. That's how we defined it last year, at least, that enables interactive exploration of COVID case data, statistical hotspots, community indicators across the US for multiple sources. So we don't just use one source of COVID data, but multiple. And it starts from the beginning of the pandemic to today, technically to yesterday. So like today's data that's on is from November 3rd. So the Atlas the goal is to provide a much more detailed landscape of the disease and helps us see things that were previously hidden. While it was developed and led by our group, it was actually developed with a research coalition that was forming in March. And another big part of this is that we had a dedication to keep everything open source and open science. So that provides a lot of restrictions because a lot of GI science tools are not open, but it ended up giving us a lot of flexibility as well. So we used a participatory design process, which basically means that we make multiple designs and prototypes, get feedback from a variety of users. So our early coalition partners were folks from Wisconsin, Berkeley, County Health Rankings, and this healthcare group, CSI Solutions, as well as a lot of different contributors and volunteers. So what you see at the top is the one that was released at the end of March 2024. So it was working, it was getting the data that you need. But as you can see in the bottom frame, that's what our map looked like a little bit later in the year. So updated the labels, made it look a little bit more savvy, more interesting community indicators and all of that. So this, and to this day, we continue to release launches as we go. So there's a lot of different data that gets into this, as you might expect. So we extract dynamic and static data across multiple domains. For COVID health outcomes, we have things like confirmed cases, deaths from multiple data sets, 1.3 acres still, USA Facts, New York Times, Johns Hopkins, and then we pulled in CDC when it became available. Each of these data sources actually have different ways of data collection and case assignment to each county. So we provide all of them so that the users can explore. And so some of the more recent data or research that we did have actually showed that there isn't necessarily one data set that's best for everyone. It really depends on where you are, what period you're looking at, and that sort of thing. And so that, again, gets a little bit complicated. We also have things like positivity rate, testing capacity, all the vaccination data. To our knowledge, we were the first to add the vaccination data, which is pretty exciting. But we also have other things, like, so for a while from the Department of Statistics at Berkeley, we were linking in forecasted deaths, at least through the end of last year. We add our own statistical hotspots and cold spots. I'll talk about that in a second. We have health systems infrastructure data, but then also a lot of different measures that would be considered social determinants of health at the county level. So this is another discussion, but finding the right community metrics at the county level is really difficult. Usually I work at smaller areas like neighborhoods, census tracts, blocks. When you're looking at a county level, it's finding the right variables can be a little bit more complicated. So we worked with county health rankings to find ones that really capture that. So we have things like, year preventable hospitalizations, proportions of how many providers exist to each person, like primary care providers, as well as, seniors, median household income, drug poisoning deaths, that sort of thing. We also incorporate multiple standard essential tools for exploratory spatial data analysis. Notice how a simple switch from the top graphic to the middle graphic, we're going from state to county level data, illustrates, just that simple switch illustrates new hotspots in the Navajo and Apache nations in the Southwest, and then the Black Belt on the southern, on the south, or in the south side. And this is a flip from the map that you see on the top. At the top, it seems like Illinois is one of the top hotspots, but it turns out at this point, that was actually just in this small location within Chicago, right? So just that simple switch from state to county level makes a huge difference. And then as we flip to a spatial statistical measure, this is the LISA statistics for those of you who've learned that in your courses. Now we can actually confirm whether or not the trends we see are accurate or not. So indeed, the Chicago hotspot persists. We have the Black Belt hotspot. We have the Navajo and Apache Nation hotspot. And this was all happening at the same time as that hotspot in the New England area. So I won't go too much into the methods of this part because that could be another talk, but that's just to kind of give you an idea. But we also have things like cartograms, dot density analysis, and we bring in overlays where you can actually overlay and just focus on Native American reservations or segregated cities. You can add clinics and hospitals as another layer, or you could look at congressional district boundaries. So we released that for the election last year. Most of the data that you see, or just how we're showing it, was actually done through multiple conversations with our partners and also users, where we would get emails from people asking for something specific, and if it was something we could do, we would implement that. So not to get into too much detail of what happens behind this, but we're actually using an inverted cyber infrastructure where spatial statistical calculations are actually being calculated in your browser. So we don't have calculations on a server and then that gets sent to the map. The map that you see is actually a different version of this open statistical software called Geoda that our center develops. So Geoda is a free open source spatial statistical software. When I did my classes in ArcGIS, like Geoda was like an additional way to do some analysis. Well, it's the same program, but here it's actually built in the browser and using this mechanism called WebAssembly, which was developed by Google a few years ago. It kind of packages it in a different way and does these live calculations in your browser. So this ties together decades of research from our center, past work on Geoda, and other open source work done in the field. So there's a lot of different folks who worked on this, and that's just like the short version. We also use an integrated data management system that shares the data that it processes with the public back in a transparent way. So the data is stored, for a long time we stored it on GitHub, but as it continues to grow every day with more data, we've since shifted to Google BigQuery. But again, all the data that we grab, we synthesize, the live data gets piped back to BigQuery, but we also added an additional feature in the past few months where you can, at any point, go to our website to the data section and just do a static like CSV download if needed, because we know that a lot of people wanted it in that way. All right, so at its heart, the Atlas is all about being a curated collection of maps and data versus a traditional dashboard. So, you know, a lot of dashboards are out there that are doing really interesting work on COVID, right? The classic JHU COVID dashboard. A lot of these are meant to provide quick overviews and at a glance reporting, like usually maybe like 1 or 2 key measures. The Atlas is instead more of a curated collection of maps, data, statistical insights. The goal is to get a personalized in-depth experience, consider uncertainty, like how does trying out a different data set impact the results, as well as multiple perspectives in design. And again, we have this kind of participatory approach to that as we go through. So this Atlas kind of infrastructure was started last year. What questions did we explore? So some of the early findings, I'll highlight 2 here. So one of the earliest findings that we had that we were early to track and identify was what's known as the Black Belt hotspot progression. So the Black Belt is a series of counties in the South that have, again, a complex legacy of slavery and much more, right? And so we started to notice there was this kind of string of counties that were, you know, turning to these hotspots. So that means the rates in those counties were very high, but also the nearby counties were also very high. So that kind of suggests that there is active outbreak and spillover occurring between different areas. So we saw that in May. It continued in June, and between that time, a lot of actually our colleagues in the South were saying like, hey, you know what, like that we have some colleagues in Georgia. A lot of colleagues noticed like that looks like the Black Belt, and so we one of the first overlays that we added were actually the Black Belt counties, so that users would be able to track that in real time. And sure enough, you know, just 1 month later, it starts to match that really nicely. But as pandemics go, it seems that over the course of many months, that was not contained, but instead expanded and continued to spill over. And so you can kind of see that by July. We were one of the first groups to kind of shout out from the rooftops as much as possible that there was really serious vulnerability emerging in rural areas. When we did a lot of different press releases and reports about this at the end of March. This was the same time that a lot of the New York epicenter news headlines was happening. So I think it kind of got washed out a bit with that. But just, for example, we saw a 93% increase since the end of May in rural areas versus urban. It really starts to get highlighted when you do those population adjustments. And one of the challenges with rural areas from past research I've done with the opioid epidemic and that sort of thing is also that it's not just the pandemic itself, but there's also less hospital infrastructure, and generally more vulnerable groups tend to live in rural areas. And as you can imagine, access is more difficult as well. It was interesting because back then, speaking to a lot of reporters who maybe weren't familiar with rural areas, they just assumed like, oh, people live so far away from each other, like there's no problems with infections. And I don't know, my family comes from rural areas on both sides, and people are very social and like to do things together, and also tend to have a different, it's a different kind of vibe. So that was something that maybe was expected, but to many people was unexpected. So that's why we really need statistics and data and reporting to kind of tease that out. And so what we were finding throughout is, unfortunately, this classic example of spatial spillover, which is, Geography 101, right? What happens in one county or state is going to impact its neighbors, especially when you think about not just communicate, an infectious disease, but how people exist in the world. So there's commuting patterns of people, right? So essential workers, even if there's a lockdown, essential workers are still moving. So that is going to impact a lot of things. There was this patchwork of policies that existed across everywhere. I mean, even within cities or within states, there were some really interesting findings that we were detecting from kind of vacation or recreation seeking behavior towards the end of those first lockdowns, where, for example, so you're seeing one example here where California had a really strict lockdown policy at the beginning. Arizona had the opposite. You start to hear news reports of Californians driving to Arizona like 3 hours away for a haircut. And then a couple weeks later, there's, interesting along traffic corridors, you start to see this spread of COVID. So we saw some similar things happening in New York and suburbs. So like the New York Times, like we shared some data with them for one of their articles about that. Same thing in Chicago, between, Chicagoans with a strict lockdown, but then surrounding states did not. So there's a lot of, natural progression that you might expect. So what protects a county with strict policies from nearby regions with relaxed rules? How our social behavior is shifted across the borders? We can use data and kind of this live interactive spatial temporal platform to explore that. Another example was using data to help actually understand patterns and behaviors that might be confusing to others, right? So people know people in their areas really well, but for example, some areas of Wisconsin, especially the northern part of Wisconsin, were significant cold spots throughout the end of July. And actually, let me take a second back here. So something else that was interesting about Wisconsin that I was initially talking about. There was a massive cold spot in northern Wisconsin for a large portion of the beginning of the pandemic. And there were reports that a lot of the protesters against the mask mandates in southern Wisconsin were actually from those areas, right? And from their experience, that makes sense, right? In my area, the pandemic is not a big deal. And at that point, it had not spread to that region. So that lived experience made sense in the context. But then you see in September how that starts to shift. So and it shifts really, really rapidly. So it's either a not statistically significant area or it's a cold spot, that's the blue areas. And just within a couple of days, we see a few areas around Green Bay light up. And then just a week later, it completely, flips. And this hotspot in Wisconsin lasted for quite some time. So I mentioned earlier, some of our earliest partners were from Wisconsin. So when we saw this map suddenly turn red, like we shared that with the Wisconsin team immediately to help them with, to catch some of this early. So while the COVID pandemic is global, it's really experienced locally. And it's difficult locally when what you're experiencing is not in sync with that global perspective. So we find that that's one of the biggest challenges with not just mapping the pandemic, but really communicating the pandemic. So, and kind of as an extension of this, how does this lead to unequal impacts of COVID? And what kinds of questions can we, can be asked to further explore this, right? So some places we've gone is, how are rural communities fared to urban areas? I've talked a little bit about that. Where do counties have essential workers who need to be at workplaces? We added an essential worker category that you could explore. How do social determinants to health play a role? That's, again, another reason why we added those specific variables. And then what sort of mobility patterns can we observe between counties? Again, that's why we added some of those levels. And to explore this, it turns out that the biggest challenge of the US COVID Atlas has been actually teaching others how to do the geography, how to do the GI science and explore these. Because there isn't usually one solution that's red, green, or yellow. It really depends on the questions and the aspects. So we think about this as like testing different ideas about the different dimensions of COVID, right? Looking at COVID case rates in one county, how does that compare to nearby counties? You can read this. So like even when the vaccination rollout was happening, how was that looking like? What about where vaccination centers were? Our goal was throughout this process was trying to interrogate ourselves, but then also our colleagues and collaborators to kind of figure out what are all the questions that we need data to explore, and then how can we fit that data into this platform so that we can then explore it. But it turns out that was still, as I'll talk about later, not enough. It gets more complicated. But first, I'll give you some kind of quick examples. So at some point, we had added a 3D choropleth map because it made a really big impact on communicating just the severity of what was happening in some places. So here we're looking at the 3D choropleth map, and we can go back in time with the atlas, and let's just, so here I clicked on the very tip of the first wave. So at the tip of the first wave, I told you earlier, this is when the atlas first came out. We knew that New York had a massive epicenter, but also, as I noted, Athens, Georgia, there was a very rural area in Georgia that was experiencing a big spike, and also New Orleans, right? So that's the first wave. Using the same exact scale, let's look at the second wave, right? The peak of the second wave, you'll notice that, New York is no longer there. Parts of Georgia are still there, but different parts of the country are experiencing surges. So one of the challenges is talking about COVID as the first wave or second wave or third wave is that not everyone is feeling that at the same time, right? It's a very local experience. Here, using the same scale, looking at December 23rd, you can see just how dramatically things have shifted. Right. And again, this is even before that massive peak in January. So just using a few kind of small visualization techniques and using the time graph, we can get really interesting insights. So here we had also added dot density maps because unfortunately you don't have data disaggregated below the state level by race and ethnicity for the whole country. So we have to do different visual tricks to get at that goal. So for example, here we're using dot density to estimate population of, in this case, like let's look at where county level Black or African American groups tend to live, and then filter that on top of the map. So here we're looking at a choropleth map of the COVID pandemic. This is confirmed cases per 100,000 people. And at the peak of the population, you can see, I mean, you guys were there, so you'll know it better than me. North Carolina had a really, was impacted really tremendously hard. But you'll also see a lot of these areas in the South also have that, similar experience. But note that other parts of the country were lower. So what's considered the worst pandemic wave in some parts of the country may not have been for others. Other examples, so we have another feature where if you open up two windows, you can, the two maps will be connected. So here we're looking at North Carolina. I figured, play to the group that I'm presenting at. So here, there's also, if you control click multiple counties, you'll be able to see multiple counties in the time graph. So this is comparing Wake, Orange, and Durham counties in North Carolina. And this is just looking at it from yesterday, November 3rd. Here I can see on the left hand, I'm looking at percent fully vaccinated. Those three counties have exceptionally high percentages of vaccination for that state, right? On the right-hand side, we're looking at confirmed cases, of population adjusted, and we can see, probably not surprisingly, that they're also on the lower end of that. Right. And then here, this is just kind of showing you a few more ways to look at this. As you hover on a county, you get some live information about that. So Wake has 67.4%, which is pretty high. That's great. You can see this graphic on the right-hand side. As you select multiple counties, it gives you a live average of the data for that. So here you can see that overall, the rates are not going up that high, and there's some other kind of key information. So let's look at West Virginia using the same kind of tactic. This was kind of anomalous, where you have some counties with almost zero vaccination rates, right? So clicking on those counties and then adding an overlay of clinics and hospitals, you can start to answer, you're not going to get the answers from this, but you can start to ask questions. Well, just looking at this, you can see that some of these areas had been hit pretty hard around January, and also again recently with the 7-day average new cases. But also you'll notice that there aren't a lot of clinics inside many of these places. So are the rates low because there's very poor access, or is it because of misinformation, complex reasoning? I also include hospitals here because that's a really important point of vulnerability, where if these areas are unprotected, and I'll notice a lot of them, it's one thing if a county is surrounded by areas that are very vaccinated, but here they're all kind of connected together, which makes it exceptionally vulnerable. And the lack of hospitals and ventilators could make that even more challenging for communities, right? So on the right-hand side, I scroll down that little sidebar, and here you're able to see actual social determinants of health. So pretty high percentage of children in poverty. Almost 1 in 4 children are in poverty in these areas, and so on and so forth. So this is kind of where you can start to see and kind of connect different pieces of information to start to, again, formulate ideas and that sort of thing. All right, so then how do we do in data? So we have all of this, but there were some kind of pretty big takeaways that came early on. Our goal was to integrate exploratory data analysis, to look at pattern detection, data exploration, and then generate and refine hypotheses. It was interesting because at the same time, there was this pressure to do kind of a different type of statistics on the data, but a lot of the classical statistical techniques we have assume that the system is in equilibrium, but we knew that it wasn't. So that kind of posed this, constant challenge. And then also the patchwork of policies, so many different elements. There's still not really a great data set of policies over the entire course of the pandemic, maybe at some points of the pandemic. Yeah, like there's just kind of like the ideal data sets that are needed don't exist, but then the data that does exist also has a lot of challenges. But even with all of that, we can still see that there are distinct spatial and temporal COVID profiles that start to show up at regional scales. So I mentioned earlier, there's really interesting things that happen in the Apache First Nation communities and Navajo Nation in the Southwest. Those were some of the areas that were hardest hit by the pandemic, but then had some of the best success in vaccination rates. So you see the results change pretty dramatically. And that's going to be contrasted to other parts of the country that have really complex, a lot of different things happening. We also found that highlighting areas with legacy racist and colonialist policies really helped reveal the disproportionate toll of the pandemic on communities of color. And this was really important because we didn't have like the data that you really need to show that of disaggregated racial and ethnic data is not available, right? So we had to use other approaches and kind of geographic thinking to uplift that a little bit more. And kind of the biggest takeaway was that access to the data and methods was not enough. And that became very frustrating for our group. I'll be honest, that was really frustrating because we just thought last year, towards the end of the year, we're just not showing the data in a compelling enough way. There must be another way to convince people that this is real. I'll tell you that I fielded a lot of questions and comments from the public about the map in those first few months. Especially a lot of folks from the South would email saying, what is this data? Like, I'm hearing COVID's not really a big deal, and you're telling me there's this many deaths. Where'd you get the data from? So I would write them really long responses and include all the screenshots and links to sources and that sort of thing, and telling them, like, please, if there's something you can share, we'd love to update it. And those conversations went they went pretty far, and they were really successful. But it seems like that one-to-one conversation, like, how do you scale that up, right? That's it gets a bit complicated, and there is a lot of uncertainty in the data. So communicating that is difficult. I'll tell you, I was trying to explain how LISA statistics work to an NPR reporter, and that was an hour of both of our lives we're not going to get back. So there's, Dr. Hitt mentioned I had a degree in writing, and that was really frustrating to know, like, there are some things I can communicate very well, but it turns out, LISA statistics was not necessarily one of them. And this is something that, if we're using techniques to do something better, we have to find better ways to do that. So again, communication across varied audiences requires really complex thinking. And then when facts are not enough, and that's another part, when facts are not compelling enough, what drives calls to action? And that's something that we're still working through. So I'll give you one example. So earlier I mentioned that a 3D graphic, we ended up adding it to the map. So this actually came from, so our software engineer who joined the team last year, Dylan, he's fabulous. We were trying to think of, like, how can we make this more compelling? And he came up with this graphic, and it just kind of shows you the spread of COVID over time and the bubbling that, our group was seeing on a day-to-day basis, but this kind of squeezes it into a couple seconds. This became viral on Reddit. And it was really fascinating, the response that it got. I think sometimes there were some responses that were like, oh, you're only showing it this way to hide, like there was accusations of that kind of nature, like to hide things. So then Dylan made the visualization many other ways, just to show that, like, no matter how you look at it, this, you still get the same impact. So this was one of our early attempts to kind of leverage that challenge. And then another kind of question that emerged through this period was, like, who is the COVID Atlas for, and who uses the COVID Atlas? So it turned out that those are two different questions, and we hadn't expected. So at the start, our focus was really, because I had worked a lot with different public health, challenges. I do a lot of mapping for local, regional, even national, like health government groups. So I knew what the limitations were within those groups as well. So our initial goals were, like, how do we get to healthcare professionals? How do we make some of the best analysis possible to, county level health department officials in a rural, under-resourced place, right? So Chicago and Madison were getting great analytic response from their local communities, but what about these more underserved areas that just don't have the same volume? So even if they're not underserved, they're not going to have the same volume of expertise as some of these large cities. So that was an early focus. Like, for example, the reason we added American Indian reservations was because the IHAS saw a version of the map and requested that, right? We also had a lot of feedback from healthcare professionals. We ended up working with journalists to kind of pair the news that they were finding with data. Another group that really emerged were businesses. A lot of businesses were using the Atlas in the first 6 months because they didn't have a national level interactive data set that provided information in that way. So they would use this, like the Atlas, along with other maps. And there were people hired to just scrape, the county information of where different factories exist, for example, for their corporation. And they would work through the Johns Hopkins app, a dashboard, they'd work through ours, and so on and so forth. And that was because of the patchwork of policies, and they were trying to gather data to determine when to reopen and that sort of thing. But we also, it was also used by advocacy groups. There was a group in Arkansas. This was included in a report to the NAACP to advocate for more resources in the Delta. and as well as the public. Like a hairdresser from Mississippi, right, was really concerned about what she was hearing locally versus what we were having on our map. And we were trying to communicate this through a lot of different ways. So, we had these viral visualizations, but we also created a Medium blog post where we would have guest perspectives. We had a guest perspective from a pastor, from a librarian. We included a lot of artists and graphic designers to kind of try to communicate information in different ways. We expanded a Twitter presence. We had an Instagram summer, the undergrads loved putting that together. So we've tried a lot of different techniques to kind of communicate the insights. And that's been a process. And so what we're finding now is that now the Atlas has really become a repository of historical information. It's become this kind of historical document in so many ways. So we're seeing, health and geography researchers use it, advocacy groups trying to look at how public health or social justice things worked out in different places. A lot of teachers, instructors, college professors are using it. I'm working with actually a librarian on a chapter of how to teach choropleth maps 101 using this. We're still hearing from some policymakers and government stakeholders, but because there was a really rapid privatization of mapping in that world and consulting, that's shifted a bit since the beginning. Also, a few journalists who kind of they'll think, we just had someone a few weeks ago, for example, who was like, well, I wonder what today was like, or how does this city compare to the peak of New York at this time period, right? So they'll have very specific questions, but then also people just interested in telling stories. And that story piece is really kind of something that we're continuing to unfurl. A question that came up early on that was very divisive was, what is a choropleth map? So at the first iteration, we had a button that said choropleth map to make a choropleth map. And I thought, well, if folks don't know what it is, this is a great opportunity to learn that, right? And to share that. And that was a debate that went back months. And I eventually lost because it became more important to just get the data out there, produce it as a thematic map, and then we can talk about what a choropleth map is in the details if people want. So, so along with this, trying to create community toolkits for a variety of different communities. So we had kind of very simple FAQ help sections, but now it's really kind of turning more into an educational tool of how to, what are hotspots, what are choropleth maps. And now we have all this body of information from those Medium posts and Twitter, and Instagram posts that we're weaving together to create these community toolkits that we'll have step-by-step guides, video series, real life use cases. So that's kind of the next atlas that we're working on this year. Another part is our brilliant software engineer. And because we used an open source infrastructure, we now have a way for communities to actually add their own data in a private setting. So because the analytics, like I mentioned before, automatically work on your own computer or your tablet or your phone, if you're looking at it, well, now you can add your own data alongside that. So if there's, zip code level data or a bunch of point data, that is something. So this isn't live yet. We're kind of working on the communication part of that, the how-to. But we do have case studies, like there's a group in Michigan that a citizen science project that captured school mask status. And so we did a collaboration with them to see how that compared against actual cases. And that was super interesting to watch over time. We've also launched a community advisory board because we know that the inequity component is so central and important. And because this is really now a historical document, we want to make sure that we're doing it justice. So we launched this. I mean, this team is amazing. So I highly recommend check this out. So the goal of this is to guide the development of a tool and efforts to ensure that we're meeting the needs of communities and organizations that were, the most disproportionately impacted by the Atlas. And kind of this also rolls over to the next step where we're actually going to be launching another big piece next year where we're actually going to add individual stories. So we've heard and uncovered so many stories since the start of the pandemic, and we know that data is not enough to convince people. And then sometimes we need those stories, even of those who didn't think the pandemic was a big deal for them, right? Like we need those stories to kind of understand alongside the data. So we're in the middle of launching this oral histories project where it'll actually link multimedia stories, audio, that sort of thing directly into the atlas is another layer. So we'll also have an infrastructure to kind of link to other, so if others, there's a lot of different projects like this out there. So the idea is to keep to our roots and link, provide a way for others to link their information to this, kind of, again, to keep that atlas kind of perspective out. So I'll just kind of jump through this last part. And so, yeah, so long story short, open science works. If you have a team, I should note that this is not something one person can do. You really need to have an amazing team that's really excited about working through this. Having that kind of sense of community coalition from the start. We were able to be creative throughout by adding multiple updates. So we got a nod from Fast Company. There's another report coming out from, I think that USC School of Price in California that show that our, the final version that we had ended up being really successful compared to some of the other dashboards out there. And of course, we've got a lot of emerging research. And so this is the academic-y part that normally would be the talk, but here I'm actually putting this as a footnote. So there's a couple that, and I can share the slides with folks if they want to look into this, but 2 are already out. One's under review and the next work is under analysis. But for example, I mentioned before that we found there are a lot of discrepancy between the COVID data sets. So the team actually investigated that and plotted out in detail, where the data starts to get off sync. And it turns out that it goes off sync at different times and different places. So there's both the spatial and temporal perspective. And then another paper looks at the social determinant of health disparities of COVID, but at urban, rural, suburban places, and then also looking at how racial ethnic disparities fit into that. So yeah, so now I say the Atlas is really a project that works to understand, archive, and represent the often unequal impact of the pandemic. This is our 6 core team, but if you go to the site, you'll see there's a bunch of additional folks who are contributors, volunteers, and that sort of thing. So hopefully this leaves kind of enough time. We've got maybe 7 minutes for questions, but apologies if it was a bit long-winded.
Thank you, Dr. Kolak. That was great. You actually got to a bunch of the questions I was writing down. You kind of circled back to throughout the talk, so I really appreciate that. So folks you can raise your hand. You can use the chat box to ask a question. And while folks are thinking and raising their hands, well, thank you for sharing the slides. There's a lot of challenges that you and your team faced here and continue to face. And I like to see the kind of design thinking, troubleshooting as you go through. But one of the things you said that I appreciated, but would like to hear maybe a little more on is, with GIS, everything is local, but COVID's a much grander challenge and a broader challenge, and as is climate change or systemic and systematic racism. And so I'm curious, how y'all are continuing to think and communicate locally, really global or at least national challenges that we face. Yeah,
I don't know if I have a good answer to that yet. it's kind of like the dream answer in so many ways, because I think it's a big challenge. And so I think that globally, all the work that GI science and the spatial stats provide is a way to identify like these are areas that are hit hardest, or there's something interesting happening here. But then like that only takes you so far to really dig in to understand like what are the actual mechanisms. It requires a kind of a different, a connection to a different, I think to a different group of people even. So for example, there was a period where we were finding there was really high vaccination rates and an outbreak happening in Peoria, Illinois. So that's like a rural area. And we thought like there has to be something wrong. Like that just doesn't make any sense. And this is just in the first month or maybe one or 2 months of the vaccination rollout. And that's something the data kind of couldn't tell us, except that this was happening. And so we looked into it, and it turned out that the senior kind of elder community was having a massive campaign and really taking vaccination seriously. So at that period, they were having some of the highest vaccination rates in the state. But on the flip side, the 20 to 30 something crowd was not taking, they were done with the pandemic, I guess, emotionally, and we're having like massive parties and just like ignoring all the rules. And there was this massive outbreak that was happening. So those things were happening side by side. It's a very local story, but it required that kind of, I guess I feel like this is where we need those coalitions where you need math, you need geographic thinking to have a view of the big picture, but then you have to, connect with, I don't know if it's journalists or community organizers or other groups locally to kind of translate that. Because it really is the whole human experience, right? And like one view kind of misses everything. I think the folks in Peoria who I ended up having some friends who lived there, so I was also interrogating them, and it was funny because they had no idea that they, like compared to the rest of the state, that anything interesting was happening there, right? So there's this kind of disconnect between those two views that I think at this point we need to just continue to try to link together and build bridges so the groups are talking to each other.
And I think to that point that you made, and Dr. Cutts also brings, like having the local knowledge and like the realization that some of these local rural stories were college towns, like being able to do that at a broader level helps when you've got a broader coalition. So John asked, he says, fantastic application. Were you able to look at the effects of redlining in more urban areas, or is this included in the hyper-segregated cities? And I'll kind of add, you mentioned segregated cities as a layer of data, and I'd be curious if you could bake what that means into the answer to John.
Yeah, definitely. So we don't have like the actual redlining pieces yet into this. Like that's kind of like a separate wider piece where we're trying to get a better translation of redlining into a measure that you could use at the county level, for example. But that came up last year where we were, because especially some of the urban environments that were hardest hit were definitely like just from our group, like we knew there were long histories of redlining and segregation. So kind of as an interim, we used, so 2 different measures. There's a Black-White residential segregation index from county health rankings. So that was one piece, that's a measure, but not everywhere has that. So that was kind of, it was hard to use that measure effectively for and we wanted like one view for the whole country. So another one of our collaborators, Dr. Lawrence Brown, he's great, and I recommend his work too. He suggested actually bringing in the cities as a layer. So we used, I think it was through Massey. There was a list of hyper-segregated cities. I think there was like one pre-2000, or there's 3 different types. We used the most inclusive type to include hyper-segregated cities over a number of decades, and they're just like the actual city boundaries. So it's just like a binary, yes, hyper-segregated, no. And for that one, I think globally, you don't see a really obvious pattern, but then locally in some places, I think that one will vary a lot more regionally, which is kind of interesting though. But it also kind of makes sense that places that were hyper segregated for a long time, like have matured in different ways. So in some places like Chicago, there's still really strong patterns that are kind of reinforced, but then in other parts of the country, depending on how the economy is changing, it may have changed. So yeah, but that one's super interesting. Okay. Oh, and then this question here. So, okay. Yes. So for AHRQ, do you mean, so we have FQHCs already. We do have a lot of poverty index measurements as well. So those are there. Aerial deprivation index is complicated because they're,
yeah,
'cause we're
specifically, I asked that one because you are working with the University of Wisconsin, and they developed that ADI over there. So because I saw the pattern in you were talking in the south part of the nation, we had those increase in the numbers. So if you go with the ACS 2019, those 5 years, if you see those patterns, you can see there is exact layers over there because of this more disadvantage, or we have more disadvantage over there. It's compatible with your pattern in your map. So I thought that maybe these two researchers can see it in close to each other. That would be very interesting for health researchers.
Definitely. And so I have kind of a weird answer to this one, because in the last research that I talked about, where we were looking at rural, urban, suburban, and county level, we do use social determinant of health indices. So we don't use one, we use 4 measures, like each show slightly different. The first measure is really similar to the ADI, and there's definitely strong relationships, 100%.
Yes.
But the reason I say it's a little complicated is like our group does research in this space too. And like, I think there's tension of like using the ADI versus others, but I mean, it shouldn't be that way. But yeah, that's something that would be really easy to add. So that would be something, because we were already going to add the other 4 measures that our group had generated. And then, because the first measure is like, okay, I'll just drop this here. And I feel bad because I feel it's like a self-promotion, but I guess it's academics too, right? So
yeah,
here,
AHRQ is the Agency Health Research. That's the combination of 7 of those variables. ADI is 17 variables, and SVI, Social Vulnerability Index, is a long list of those variables. So, and they have a lot of collinearity together. So that was a kind of suggestion that maybe if someone wants to see those patterns and say that, okay, I need this, I want to, because I have seen this one, especially now I work with Duke, and at Duke, we have a lot of this research. For instance, one of those PI wants to see these specific indexes. The other one wants to work with that one. So with this beautiful atlas that you have made, so maybe it makes it much more easier with them, to go and do their research. So that was a kind of question, suggestion, whatever.
No, but I think this highlights an important point where, like for me, I'm not a fan of overusing an index, but if everyone else is doing it, then we have, then doing something that is the best for the bigger group has to be the most important thing. So I think that's why, like, even adding certain data sets, COVID data sets, there were some that we just didn't agree with how they were including data, but then we decided to include all of them so that people could explore and choose on their own. But I think there was that tension of like, we're selecting like what we include or not include reflects how we view it. And so that's something that, I think it's important for us to keep on being pushed. But yeah, like the Childhood Opportunity Index, we were talking about.
That's another one, yes. And the new one, Pandemic Vulnerability Index, for instance, which is, they are using it a lot these days.
And I have strong opinions about that as well. But I think that's a great point where if we can actually show what they all look like in the same infrastructure, then that's probably one of the best ways to kind of decide what's the best measure to use, right?
Thanks.
Yeah, I think that's a great point to end on, like how much these decisions with data science and geospatial science lie with us as the researchers, and working together and broadly, and working with communities to make sure that it's open and accessible, and that other folks can make some of those decisions for themselves, and knowing the biases and limitations for sure. So we're at time. Thank you very much, Marynia. That was really interesting. It was really interesting, and I really appreciate your time today. If you're available to hang on, it looks like there's another question or two, but if you've got other things to get to, I certainly understand. A reminder for the students, staff, and faculty who are on or near campus, that there is going to be a happy hour and a celebration of the end of a Thursday down at Ruckus Pizza. So head on down there. But we greatly appreciate your time and sharing. And I think there's a lot of fantastic information there about data literacy, equity, and open science. So thank you very much.
Yeah, thanks, Marynia. And that was great. I echo Aaron's